In this section of the lecture, we will be discussing complement. So complement is a system of over 20 serum proteins that are synthesized mostly by hepatocytes. There are 9 main components, labeled C1 through C9 conveniently, and 3 activation pathways that all merge together. Those pathways are the classic pathway, the alternative pathway, and the lectin pathway. The classic pathway is antibody-mediated. The alternative pathway is induced by microbial surfaces, and the lectin pathway is promoted by mannose-binding lectin. All 3 of these pathways, as I mentioned, merge and result in cell lysis via the membrane attack complex, or MAC. Let's examine each of these pathways individually. Now, it's important to note that memorizing each of these pathways at an individual specific level is probably not necessary for the boards. However, it's a good idea to understand the processes and certain key proteins that are involved that we'll discuss throughout this process. So beginning with the classical pathway. This pathway involves C1 through C9, and also, as I mentioned, involves antibodies. So this pathway gets started when you have antibodies that are binding to the cell membrane of a bacteria, any type of surface. Antibodies that are most functional in this aspect of complement are IgM or IgG. If you have one IgM pentamer, that can activate complement all by itself, making it a very efficient complement activator. With IgG, you need at least 2. So these antibodies bind to the cell membrane, bind to the bacterial cell surface, and then the C1 protein comes in, as you can see starting on the left, and binds to the Fc portions of those antibodies. Once C1 is bound, then C1 recruits both C4 and C2 and splits these proteins into subunits, both A and B. Now, if you'll notice, you can recognize a pattern here. The B subunits stick to the membrane, they are bound, and the A subunits float off. You can think of them as aqueous if you would like. So 4 and 2 are split into 4B and 4A and 2B and 2A. 4B and 2B stick to the membrane, and 4A and 2A float off. This heterodimer of C4B2B is known as C3 convertase. It has enzymatic activity that allows it to separate the next protein in the cascade, C3, into its subunits. So C4B2B, or the C3 convertase, will grab C3 and then split it into 3B and 3A. 3B sticks to the membrane, it's a B subunit, and 3A floats off. So now we have sticking to the membrane 4B, 2B, and 3B. If all 3 of these are together forming a heterotrimer, that becomes C5 convertase. Now, this C3 convertase is going to break down more than just one C3 protein. It can break down many. So if it's not binding to that C3 convertase and forming C5 convertase, the excess C3b will be stuck in the membrane, and it can actually serve to enhance phagocytosis. It's an opsonin, and it will allow phagocytes to come in and bind to C3b receptors that are on the phagocytes and enhance phagocytosis. So not only do we punch holes with complement, but we actually enhance phagocytosis through this C3b. So that's the excess C3b. Now again, going back to the pathway, this 4b, 2b, 3b heterotrimer, called C5 convertase, is actually involved in grabbing the next protein, C5, and splitting it into its subunits, C5a and C5b. C5b sticks to the membrane, C5a floats off. C5b is involved in recruiting the rest of the proteins that will make up what we call the MAC, or the membrane attack complex. C5b recruits C6, C7, and C8. These proteins don't split up into subunits. They come in whole, and they bind into this complex. So we have 5b, 6, 7, and 8. Once we have those 4, then we get the recruitment of C9. And as you can see on the right side of the diagram, we have multiple C9 proteins that will come in and form a ring. That ring is actually what will then punch down through the membrane and make the hole. So what we see at the end result is this MAC formation, which punches a hole in the surface of the bacterium. Once you punch these holes, now all of the cytoplasmic contents can leak out, and that will effectively destroy that bacteria. Another important point to make on this classical pathway are these subunits that are floating off. 3A, 4A, 5A are all anaphylatoxins. They're very good at chemotaxis, and specifically calling in certain arms of the immune system, which we'll see in a later slide. So just in the overview sense, 3A, 4A, 5A are good anaphylatoxins. They're good chemotactic agents. All the rest of them, all the Bs, 4B, 2B, 3B, 5B, stick in the membrane, involved in converting the next down the line. 4B and 2B involved in the C3 convertase. 4B, 2B, and 3B involved in the C5 convertase. And then 5B involved in creating the MAC complex. Not too hard to remember. It starts with 1, it ends 5, 6, 7, 8. The only things that are out of order are 4, 2, and 3. So you just have to take 4 and put it before 2 and 3. So if you just remember 4 comes before, then now you've got the classical pathway. No problem. The lectin pathway is identical to the classical pathway with the exception of the very first step. Instead of having the antibodies and C1 binding to those antibodies, we have what we call a mannan-binding lectin. This mannan-binding lectin looks for bacterial carbohydrates such as mannose. It binds to the mannose, and on this MBL, this mannan-binding lectin, there's a collagen-like domain that can actually activate C2 and C4. Once we have activation of C4 and C2, then everything else is the same. Those two will split. The 4B and 2B form the C3 convertase, grab C3, which will then be split into its subunits. We have the formation of C5 convertase as well as excess C3b again being placed in the membrane. 4b2b3b, the C5 convertase, will then convert C5 into its subunits, and we get initiation of the MAC, just like we saw in the classical pathway. Now the alternative pathway is a different beast altogether. And the reason that this pathway occurs is because of it starts with the spontaneous generation or the ability of C3 protein to spontaneously split into C3a and C3b. It's kind of an unstable protein and it doesn't require C3 convertase in order to split into its subunits. It can just spontaneously split. Therefore, if you have a membrane of a bacteria, a membrane of any type of cell, as a matter of fact, that doesn't contain inhibitors, this C3b can accumulate. Could it accumulate on one of your cells? Absolutely. How come it doesn't? We'll talk about that later. But just get the general idea. This is innate. It's not specific. That C3b, if it finds a membrane, it will stick to it. It doesn't care what it is. So if there's a bacterial membrane out there and there's some C3b out there, it will stick to it. Now, what happens next? We have the spontaneously generated C3b stuck in the membrane. We have activated factor B. Following along, step 2, activated factor B will come in and bind to that C3b. Now, a third protein called activated factor D will come in and cleave factor B into its subunits, BA and BB. So now we have in the membrane 3B and BB stuck together. This is held in kind of a stable formation by another factor called properdin, or factor P. So now we have the stable 3B-BB, which is a C3 convertase. It can grab more C3, and just like in the classical and lectin pathways, it can convert the C3 into its subunits. And so the C3a will float off, the C3b will stick in the membrane, and just like with the other pathways, we have excess C3b sticking in the membrane that can lead to opsonization. Certain C3b will stay with that convertase, and now we have a heterotrimer of 3b, bb with another 3b, and that trimer is a C5 convertase. It can grab C5, split it into its subunits. C5b will stick in the membrane, C5a floats off. With C5b, we have, again, recruitment of 6, 7, and 8, just like in the other pathways. Once those 4 are together, we have recruitment of 9. We form the ring. The ring will insert itself into the membrane, and we have holes once again. So that's the alternative pathway. Again, remember why it starts. Spontaneous cleavage of C3b sticking to a membrane. We have all of these other activated factors that will come into play. And then at the end of the day, we have formation of MAC complex. We have excess C3b stuck in the membrane, which will act as an opsonant and increase phagocytic abilities. Just as a note, because weird things sometimes pop up on the boards, there are some certain things that are associated with the alternative pathway specifically. LPS, IgA aggregates, and cobra venom, as a matter of fact, have been shown to be specifically associated with the alternative pathway. So if you see one of those things popping up in the context of a complement question, think alternative. All right, here we have a good overview slide of the 3 pathways and how they come together. Remember we said that at the end they all merge, and we can see that very distinctly here on the right side of the slide. From C5 on, they're all the same. Classical, MBL, alternative, they're all the same. The difference is how they get started. So starting on the left, classical starting with that C1, mannose binding lectin starting with that MBL, both of them leading to activation of C4 and C2. So at that point, even the classical and mannose binding lectin pathways are similar. They come together at that C4 and C2, and we get cleavage of the proteins and formation of the C3 convertase. Remember, it's all about getting to that C3. Once we have the C3 convertase going, then the C3 gets divided and we can head down the MAC complex pathway. The alternative pathway, again, starts at C3 right in the middle of the slide with a spontaneously cleaved C3b, which will then grab factor B, and we remember we get that 3b BB heterodimer, which will then cleave more C3, and we get the 3b BB 3b heterotrimer. So we have that loop leading to 5 splitting into A and B. So this is a good slide to kind of picture it, make a mental picture of it, have it in your mind to be able to distinguish the 3 complement pathways. So here we have kind of another overview of what's going on. We see on the left, again, what we talked about, alternative classical lectin pathways, all with different starting points, all with that early step leading to excess C3b. That C3a has an effector function in that it's inflammatory, it's an anaphylatoxin. C3b likes to opsonize, involved in phagocytosis. And then kind of going through the later steps, we have cleavage of C5 into its subunits. Again, C5a is an anaphylatoxin. C5b leads to the formation of this complex, leading with the C9 ring that will then punch holes in the cell. On the right side, kind of a word diagram, if you're used to seeing those, if you're more comfortable with those, saying the same kind of thing. Things that we've been over already. Different pathways, classical lectin, alternative pathways, all kind of leading down. Look at the bottleneck right there through the C3 convertase, and then activating that common pathway through C3b, leading to opsonization, formation of the MAC complex with lysis of pathogens in cells, and then the 3a, 5a, and to some extent 4a, recruiting phagocytosis, degranulation of mast cells and basophils, and inciting this anaphylatoxic type of response. So if we want to see kind of opsonization working here we have the classical pathway with that C1 leading to excess C3b, and it kind of creates this zone of deposition. As this excess C3b gets created, we get more and more C3b being stuck to the surface of the cell. We have this aqueous portion, the C3a, that floats off and activates macrophages. And then we see here our lovely looking macrophage come in. It has C3b receptors on the surface of its cell. Those C3b receptors can recognize the C3b, and that will clue in the macrophage, hey, this is a bad guy, it's coated with C3b, let's get rid of it. And that macrophage will then phagocytose that bacteria, and we can get rid of the infection. So a question, 46-year-old female with AML is day 5 status post-stem cell transplant. Her absolute neutrophil count, or ANC, is 100. She spikes a temperature of 40 degrees centigrade, and the lab reports gram-positive cocci and chains from her blood smear. The complement pathway in this patient is activated by antigen-antibody complexes as well as by, which are the following: A, microbial surface, B, IL-7, C, IL-1, D, IL-4, E, TCR, F, this patient would not mount a complement-mediated response. The answer here is A, microbial surface. So let's take a look at these. Again, what's this question telling us? We know that it's a complement question. We know that one of the ways it's activated is by antigen-antibody complexes. That's the classical pathway. What else activates complement? What else here in these questions, or in these answer choices, is specific to complement? Well, A, microbial surface, we know that that is what activates the alternative pathway, right? We said that all the alternative pathway needs to get started is some type of membrane. So that can activate the alternative pathway. IL-7, remember, is involved in T-cell differentiation and T-cell maturation, not involved in complement. IL-1 is a general inflammatory mediator, not really specific to complement activation. IL-4 is the same, more involved in a Th2 type response. T-cell receptor is involved in adaptive immunity, so we're not really thinking about complement there. And then F, this patient would not mount a complement-mediated response. There's nothing to suggest that she wouldn't remember complements made by the liver. Even though she's status post-stem cell transplant and may not have a whole lot of white blood cells, that doesn't mean that her liver's not functioning. So we can kind of rule F out as well. A makes the most sense, again, antimicrobial surface being all that you need to activate the alternative pathway. Continuing on, the following day, the lab reports an error and states that the blood smear was actually from a 6-year-old girl. You find out the girl is not immunocompromised. The common pathway of complement in this case is designed to produce which of the following? A, T-cell activation, B, B-cell activation, C, bacterial membrane lysis, D, strep pneumoniae specific immune response, and E, immunologic memory. And the answer here is C, bacterial membrane lysis. Again, this is a complement question. Complement is part of the innate immune system, so even at the very basic level, you can break this question down. A is T-cell activation, B is B-cell activation. Those are adaptive. That's not complement. D is strep pneumo-specific immune response. That's adaptive. E is immunologic memory. That's adaptive. Again, you can rule those out. So even if you didn't know that the end result of complement is bacterial membrane lysis, just by process of elimination, you can get to C in making broad inferences. This is a complement question. They want innate function, not specific function or adaptive function. Another question, a deficiency in the complement C4 protein will lead to dysfunction in which of the following pathways? A, classical pathway only, B, alternative pathway only, C, mannose binding lectin pathway only, D, classical and alternative pathways, E, classical and MBL pathways, or F, alternative and MBL pathways. So with these type of questions, what I like to do is break down, looking at them individually, and then we can kind of, whenever we have an and, we can kind of decide from there. So if you have a deficiency in complement C4, will you have a dysfunction in classical pathway? Yes, C4 is involved in the classical pathway. How about the alternative pathway? No, C4 is not involved in the alternative pathway, so you wouldn't have a dysfunction. And then C, the MBL pathway, would you have a dysfunction there? Yes, you would. So you would have dysfunctions in both classical and MBL, and that leads to the correct answer, which is E. Another question, a deficiency in C5 convertase would lead directly to deficiency in activation in which of the following cell types? B cells, T cells, mast cells, macrophages, or basophils? The answer here is macrophages. Why? A deficiency in C5 convertase, remember, would lead to a bottleneck right there at the C5 step, and you wouldn't have the ability to break C5 into its A and B, and you wouldn't get that anaphylatoxic effect. Now, why macrophages specifically? Well, that kind of leads us into this next component of complement, which we'll talk about here. So going to the next slide, we have additional actions of complement other than just making that MAC complex. Remember, we talked about that being the end result, and we see that as the third action, killing of pathogens, making that ring, destroying the membrane, the ability of the membrane to hold the cytoplasmic molecules in, and basically getting rid of the cell. So other things that we do with complement, remember, we recruit inflammatory cells, C3a, C4a, C5a. Those are anaphylatoxins. They're involved in inflammation, vasodilation. They're chemokines, so they recruit certain cells like we saw in that last question. They're also involved in opsonization, specifically C3b, involved in coating bacteria and making it more available for the phagocytes to be able to take care of that cell, to endocytose that cell. They're also involved in clearance of immune complexes, and this becomes important when we talk about type 3 hypersensitivity. So keep this in the back of your mind. Immune complexes are antigen-antibody complexes which are found in the blood, where we have soluble antigen being bound by antibodies, forming this sort of web or tumbleweed, if you will. The complement can bind to these immune complexes, and then through activating different phagocytes like neutrophils and macrophages, cause the breakdown of that immune complexes. So other types of actions that complement has. Now, getting to the effects of C3a and C5a. Again, anaphylatoxins and chemoattractants, and we're going to get a little more specific here with C3a and C5a. C3a specifically activates mast cells, basophils, and eosinophils. So think of this in terms of an antiparasitic type of response. We get release of histamine. That's where that anaphylatoxin comes into play. We get permeability of the capillaries that allows that extravasation, allows the other types of inflammatory response that we see. So C3A is specific to those granulocytes, mast cells, basophils, eosinophils. C5A tends to attract more of the phagocytes, the neutrophils, the monocytes, the macrophages. So think more of an antibacterial type of phagocytic response with C5A. Now C5A to some extent also can activate eosinophils, so it's involved also with that antiparasite response. But for kind of broad strokes, if you want to paint, C3A is the granulocytes, the antiparasitic type of response. C5A is the phagocytes, the antibacterial type of response. Therefore, as we saw in that question, if you have a breakdown in C5, then what you get is the inability to recruit these phagocytic cells. You would have a decreased activation of macrophages, the neutrophils, and monocytes. So, next question. A 2-year-old boy is being evaluated following recurrent ear infections and 2 hospitalizations for pneumonia. Serum tests reveal that immunoglobulin levels are normal. Further testing reveals decreased phagocytic abilities. Which of the following molecules could be deficient in this patient? A, C3A, B, C3B, C, C5A, D, C5B, E, C6, F, C7, G, C8. The answer here is B, C3B. So what are the clues in this question that kind of tip you off towards C3B? Well, we know he's got recurrent infections, so we know that he has some kind of immune dysfunction. Serum tests reveal that immunoglobulin levels are normal, so it's not a B cell deficiency. Further testing reveals decreased phagocytic abilities, so they're having the ability of the phagocytes to come in and endocytose cells is decreased. Well, what would cause that? Think about things that allow opsonization, antibodies or C3b, right? Well, we know the antibodies aren't dysfunctional. It says that our immunoglobulin levels are normal. So that tends to point more towards this complement, this deficiency in the opsonin component of complement, which is C3b, and that's our answer. Now, I mentioned that complement can get started on any cell, especially the alternative pathway. All it needs is a membrane. So what prevents complement from being activated on the cell surfaces of your own cells? Well, we have certain types of regulatory molecules. For example, C1 inhibitor degrades C1q. So this would be involved in which of the pathways? Classical pathway, right. DAF, or decay accelerating factor, also known as CD55, is present on self cells, and it dissociates C3 convertases. So if the pathway gets started and gets to that C3 convertase step, no matter how it got there, this CD55 can dissociate those subunits and therefore inhibit the progression of the complement cascade. MCP helps factor I degrade C4b, so there's another step in the cascade that we can prevent, and CD59 or MIRL inhibits MAC formation. So at multiple steps along the pathway, we see at the initiatory step, at the convertase step, all the way down to the MAC step, we have different regulatory proteins that can prevent complement from punching holes in our own cells. Good idea. Now, what happens if we have some deficiencies? Of course, we can either have deficiencies in components, or we can have deficiencies in regulators, right? So we can kind of categorize this in 2 different mechanisms. If you have a component deficiency, then your problem is going to be what? Infectious, right? You're going to have a problem dealing with the pathogens. So what we see here, for example, if you have MAC deficiencies, deficiencies anywhere from C5b through C9, these people tend to be susceptible to Neisseria species for whatever reason. Now, if you have component deficiencies early on, C1 through C5, this produces more of a variable type of immunodeficiency, and it varies from patient to patient. Some of the common things that you see are sepsis, and often recurrent infections with encapsulated organisms. So complement's very effective in dealing with these encapsulated organisms. And so if you have deficiencies in any one of those cascade components, you're going to have problems. Now on the flip side, if you have regulator deficiencies, you're going to worry about some type of autoimmunity, autoinflammatory type of picture, right? If you have C1 inhibitor deficiency, that's associated with angioneurotic edema or hereditary angioedema. You might see it listed as that. And these are people that have some sort of minor trauma, some sort of minor infectious agent introduced, and the complement pathway gets started, and complement just starts binding to everything. And like I said, it can get through and binds to your self cells as well, it can start the C1 inhibitor, or without the C1 inhibitor, you can start the early component of the pathway. You can get to the C3 convertase. And even if you stop it after the C3 convertase, well, at this point, you've created what? C3A. That's the anaphylotoxin that can lead to what? Vasodilation, swelling. That's what causes this edema. So C1 inhibitor deficiency, people get edematous. Hands, feet, face, swelling. If you have deficiencies in CD55 or CD59, those are associated with PNH. And PNH stands for paroxysmal nocturnal hemoglobinuria. So again, PNH associated with CD55 and CD59 deficiencies. So how about this question? A 6-month-old infant has a history of multiple viral and bacterial infections. It is discovered that his antigen-presenting cells are defective in presenting antigens. Which of the following will not be affected by this condition? A. Antibody production. B. Helper T cell activation. C. Cytotoxic T cell activation. D. Complement activation. And E. Macrophage activation. The answer here is D. Complement activation, right? Looking at this question, we have what? We have defective APCs. So we're going to have defective what? T cells. Adaptive immunity. So right away we get rid of helper T cell, cytotoxic T cell. If we don't have antigen-presenting cells working like they're supposed to, we're not going to get T cell activity. Antibody production and macrophage activation will also be affected. Why? Because they don't have that stimulation from the T cells. Remember, B cells and even macrophages to some extent require that crosstalk, those cytokines that are made by the T cells. And so the one that you're going to have working without being affected is the complement here. Again, made by the liver, they're out, and they don't require any T cell help to get started. So here we have some complement pearls. Again, famous pearl slide. These are things that you have to know about complement going into the boards. Classical pathway utilizes bound antibodies. The alternative and lectin pathways are antibody independent. Remember, alternative pathway, you just need a surface. Lectin pathway, what you need is that MBL. C3A and C5A, potent chemoattractants. Remember, C3A is associated with kind of anti-parasite. C5A kind of associated with phagocyte, antibacterial. C3B, great opsonate. Defects in the MAC cause Neisseria susceptibility. CD55, CD59 loss causes PNH. CD1 inhibitor deficiency causes angioneurotic edema. And inflammatory states or autoimmunity, another important point here, reduce complement levels by consumption. So we'll get to this again when we talk about hypersensitivity and autoimmunity. But if you have a chronic inflammatory state, you're going to see low levels of complement. Why? Because this complement is constantly being activated by all of the antibodies that are running around. So one of the markers of autoimmunity is reduced complement levels. And again, we'll get to that a little later when we talk about autoimmunity. Now, what happens if these critters can evade innate immunity? Remember, we said this is our first line of defense. This is the first thing, and this is actually the thing that innate immunity takes care of most of these bugs, but there are bugs that can get through. They've evolved mechanisms where they can get through. So let's look at a couple of these and see how the bacteria are getting smarter. Resistance to phagocytosis. Certain bugs have evolved capsular polysaccharide types of envelopes, if you will, types of milieus that surround the bugs, these polysaccharide shells that can make them resistant to phagocytosis. Pneumococcus is famous for this. Another way that they can resist phagocytosis is to escape from the phagolysosome. They can be engulfed into the phagocyte and then escape into the cytoplasm, and Listeria is a classic example of this. Resistance to reactive oxygen species. We talked about this when we talked about CGD with staph, catalase enzymes that allow them to kind of escape that part of the respiratory burst. And then resistance to complement. Neisseria has sialic acid that inhibits certain convertases, which make it resistant to attacks by complement. And streptococci actually produce an M protein, which blocks complement binding and complement receptors, which allow it to escape the effects of complement. So we see that there are certain bacteria that have evolved mechanisms to evade innate immunity, and for that we have to have our specialized arm, our adaptive immunity. That concludes our discussion on complement. In the next section we will have an overview of adaptive immunity.